Thanks for joining us here on 9 News Plus. I'm Chris Bianchi. We're now approaching 4 years. Hard to believe, but we're approaching 4 years of COVID, and we're clearly still talking about it. In fact, there's a notable increase in cases of COVID in both Colorado and across the country recently. So joining us with a bit more about this and how we should be approaching it is 9 News medical expert Dr. Payal Kohli. Dr. Kohli, before we kind of get into some of the specifics around this increase, what is driving this increase in cases?
Chris, I think much of it is our behaviors and change in our behaviors because obviously we have let our guard down, right? We are socializing more than usual. We don't see a lot of people wearing masks in crowded indoor spaces, but part of it is also that the virus continues to evolve. So we have seen a number of new variants emerge after Omicron, variants that have been more infectious, more contagious, and spread more efficiently. Thankfully, none of them seem to be causing people to get sicker. And that could be a function of the variant itself and also a function of the fact that at this point, many of our immune systems are no longer naive. They're more mature. We've either been vaccinated, had the infection, or both. So many of us walking around at least have some level of defense against these variants. But I think it's a combination of shifts in the virus, shifts in our behavior, and the natural pattern. And as we head into the fall, back to school, we're going to see a surge in respiratory viruses, whether that's flu, that's RSV, or even COVID.
How does this increase that we've seen, we're saying this is the first week of September, how does this increase compare to other recent surges? I think about the one in late 2020 and the one in late 2021.
It's almost impossible to tell because we have a blindfold on at this point, right? Because many of us are not testing. Even if we test positive, many of us are not reporting it to the state. So in a way, the way we assess whether COVID cases are going up is by looking at the end point. Where do people end up when they get sick with COVID? In the hospital. And that is being reported. So looking at hospitalizations, we are seeing an increase in hospitalizations, but it's a much smaller magnitude than we have seen in previous years. So even though the trajectory seems like it's going up, which is not unexpected because of the factors we talked about, thankfully the peak of that mountain is a lot lower than it was last year. The other thing that helps us to sort of know what the virus is doing is the wastewater surveillance that we're doing. So what that is they actually look at sewage water and look for viral particles because we know that the virus lives in our gut as well. And if you're positive for the virus, you go to the bathroom, you actually end up shedding pieces of the virus in the wastewater. So they're looking to see levels of viral antigens or viral proteins in the wastewater as a way to get a sense of what the virus is doing. But because we're not reporting as much, it is a little bit trickier and a little bit more of an apples to oranges comparison.
How should we be thinking about this now with this increase? And it sounds like, to what you're saying, it seems somewhat inevitable.
I think we should be thinking about our individual risk. So no two people are going to have the same formula for what they should be doing. And the biggest driver of that is your individual risk. So who are we seeing ending up in the hospital? It is the elderly people, as the ones with comorbid illnesses. So I would categorize those individuals as the highest risk category. In fact, my patients that have heart disease that are elderly, if I see them in the office, I'm telling them to put masks on in crowded indoor spaces, in the grocery store, in the shopping malls, in airplanes, in airports. Because now that we're seeing the virus increase, we have to employ the countermeasures that we're now aware of. And that's the good news. We've learned how to think about these countermeasures. So those people definitely need to mask up. I would implore everyone, regardless of their risk, to use testing liberally, which many of us have stopped doing because the tests stopped being free. Some of them expired. You're not supposed to use expired tests anymore. But really we need to get back into that mode of, hey, I've been exposed, I need to test. Or, hey, I'm going to go see my grandma, who is high risk, even though I'm not high risk, but I've been going to Whole Foods without a mask on, so maybe I should test before I go to see her. So I want us to start doing that. And then the usual things we talked about for respiratory season, hand washing, not touching your face, making sure you wipe down surfaces, especially for our little ones going back to school now. It's really, really important to emphasize those.
Yeah, it's really good insight. Now, specifically about this variant, give us a bit of insight about it and maybe why is it more or less concerning the previous variants?
We're a little more concerned about it. We're keeping our eye on it. And the reason for that is because it's what we call a massive number of mutations. So the other variants, when they went from one variant to the next, it was a couple mutations here or there. This one has 36. And all of those mutations are concentrated in the spike protein, which is kind of like the arm of the virus. It's what the virus uses to hold on to our cells. That's the protein that it uses to get into our cells. That's the protein that we made antibodies against when we get sick. That's the protein that we're vaccinating against. So the vaccine antibodies are against that protein. So if that protein changes enough, it can be a little smarter, a little bit better at evading our immune system, so it can get into our cells without our immune system sort of really activating. And so that's the challenge with this variant, is the fact that it has so many mutations. Now, what we're watching is it more contagious because of those mutations? Is it more efficient at spreading? Is it going to make people sicker? Thankfully, so far, that doesn't appear to be evidence that it's doing that. Do our antivirals like Paxlovid still work against it? And they do seem to be working against it.
Okay.
Do our tests still work to detect this? So would we still test positive? And the answer to that, too, is yes. So thankfully, it's been good from that perspective, but we're still watching it really closely.
Okay, some good insight there. There's also, of course, a new booster coming out in the middle of September. And who should be thinking about getting this, and will that booster cover this new variant?
So pretty much everyone should think about getting it. I would say everyone should get it if you've been at least 3 or 4 months since your last infection or your last boost. You need to give your immune system a little bit of a refresher for the fall season coming up. But definitely who should get it are the older individuals, those with medical problems, anyone who's immunosuppressed, the ones that we talk about being high risk absolutely should get it. But for the rest of us, it's a good idea. If it's been at least 6 months since your last boost, it's been at least 3 or 4 months since your last infection, you ought to go and make sure that you buff up those antibodies. Now, it's interesting you asked me about which variant it covers, because by design, we're sort of one step behind the virus, right? When we design the boosters, we design it according to the dominant variant at the time, which when this booster was designed was XBB. Now, XBB is a grandchild of Omicron. So think about Omicron as a grandparent, and XBB is one of the grandchildren of it. And so that's what this booster is designed against. It's monovalent, only that strain. The one that we're concerned about now with the 36 mutations and another one that are out there, there's one called EG5, which is the child of XBB. So we think if we cover XBB, we'll probably cover EG5. But then this other one that's circulating out there, that's called Pyrola or Pyrola, that 36 mutation is related to Omicron through a different lineage. So it's descends from Omicron, but it's more like a child of Omicron. So think about your family tree, and you're similar to your cousins, your aunts and uncles. There's some characteristics that overlap. So we hope that the vaccine will at least have enough overlap that it'll cover some of these. Having said that, again, the vaccine is designed against the spike protein, the ARM, which is the part that's changed. And so really have to sort of wait and see. What I would like to see ideally, honestly, is that we put in a second, a Pyrola or Pyrola variant into this booster as well, so that we do have better coverage. But this variant may die out. So, it could still end up being mostly XBB or EG5 that we end up seeing.
That's a really good analogy, a good way to think about it. Other variants at this point, probably inevitable, right? That we're going to have more and more of these variants, and how will they evolve, and how does that work?
Think about your family tree, right? People get married, people have children, and they keep evolving generation after generation. So this virus at this point has become endemic. We're living alongside it. We're not going to eradicate it. It's not a pandemic because it's not sort of out of control and it's not unpredictable. It's not taking over rapidly in terms of its growth. But we are going to continue to see, just very much like the flu. Every season we have different kind of flu shots that are based on the activity we see in Australia and the Southern Hemisphere. We're going to do much of the same with this virus at this point. We want to keep hoping that the new variants continue to follow that Omicron sort of behavior, where they're not so angry, they're not so virulent, they don't make us so sick. But if they change enough, they could very easily revert back to what happened with Delta, which had a lot of mutations as well, where it was getting people into the intensive care unit in the hospital. So that's why I want us to really be adaptive in our thinking about this. Not, COVID is done, we're over it, but more, let me keep up with what's happening so I can continue to adapt my behavior, live my life to the fullest without the virus affecting me.
And with that said, so I think we are entering a realistic new phase where I think lockdowns, things from before, are very, very unlikely. At this point, that's the way it appears, and that's a combination, I think, of actual science and social science.
For sure.
And I say that also as well as, let's say we are exposed, and Dr. Jill Biden, the wife of Joe Biden, just contracted COVID-19. I think on Labor Day weekend. Joe Biden, I think, wore a mask around the White House.
Yeah.
How should we act if we are exposed to the virus?
Yeah, very good question. So you want to think about your degree of exposure. So how close was the contact and for how long? And if it was prolonged contact or it was a pretty close contact, you pretty much want to consider yourself exposed. You also want to think about when in the person's illness you got exposed to them. Was it early, mid, or late? Because when they're most infectious is the early and mid period. When they're late, it's kind of the immune system's kind of taking over and they're not quite as infectious in terms of giving off viral particles. And then you want to sort of, almost like we say, presumed innocent until proven guilty. This is the opposite. You want to prove that you're guilty basically until innocent. So you almost want to think like you're shedding and be very mindful of who you're around. Now, wearing a mask would be the most conservative thing to do. I applaud it. If that's something that you're not able to do because of your circumstances or your work or what have you, certainly mask up around high-risk people, but testing is the key there. And I would recommend after exposure to test at least 1 or 2 times a day, even if you're asymptomatic, no symptoms at all, feel great. Because at the first sign that test turns positive, it tells you you're shedding enough virus that you're obviously possibly infectious to somebody else. And then it could, of course, influence your decision of whether or not you want to start Paxlovid for yourself if you do end up testing positive. You want to do that early in the course of the illness.
Okay, so good things to think about. Anything else to think about or add about how we should be thinking about COVID right now?
No, like I said, I just want us to be adaptable. If we do get exposed, I want us to test for at least 5 days after exposure. After that, you're probably in the clear if you're continuing to test negative. And I want us to go into the fall really thinking about prevention, because we want our life to continue with the way that it's been continuing. And for individuals over the age of 60, this is the first year that we also have an RSV vaccine. And I would strongly recommend everybody get that triple shot, that COVID booster, the flu shot, and the RSV vaccine. A lot of people ask about timing and when they should get it. And I like to use the mnemonic flu before boo. So you definitely want to get it before Halloween because that's your boo. So you want to make sure you're vaccinated before Halloween. You probably, Labor Day is kind of the earliest you should get it, but I would say mid to late September when the leaves start to turn color. That's a good time to go and get your immune system buffed up and ready for the fall. Get those triple vaccines if you're older. If you're not older, you need your flu shot and your booster vaccine as well.
Good thoughts. All right. Well, Dr. Payal Kohli, thanks so much for joining us here on 9 News Plus.
Thanks for having me.